that many institutions who are doing palliative care is concentrated only on cancer. But does that mean that patients who have non-cancer illness, don't they need palliative care? So there is a systematic review which has been conducted, and it has compared, I think, about 6 diseases, and it has seen that the patients with non-cancer disease also suffers the same symptom burden as that of cancer. So it is important for us to understand that palliative care uh, cannot or should not concentrate only on cancer care. It should also concentrate on any other diseases in which the patient has a serious health related suffering. So this session will be taken by Dr. Sunitha Daniel. So Dr. Sunitha has done her MRCP in medicine and MRCP in palliative medicine from UK, and she has been working in UK, and right now she is working as a specialist palliative care physician at General Hospital Ernakulam. She has many years of experience in palliative care, and um, she has been teaching. She has a special interest in teaching. Welcome, Sunitha, and it's over to you.
Thank you, Dr. Sunil, and thank you, Rajarashmi. Thank you, Team Pally in India, for attending the opportunity. So today, as Dr. Sunil mentioned, we'll be discussing on what is the role of palliative care for non-cancer illness. What I would be, it is a vast topic. So what I would like to do is first, I'll let you know what I'm aiming to cover in this session. Just to give a brief an account of why the non-malignant diseases, why the patients will benefit from palliative care, and briefly mention in a couple of slides about these diseases like COPD, heart failure, dementia, other neurological conditions, end-stage kidney disease, major psychiatric illness, and frailty. So this is what was given in the schedule. So I'm concentrating on just on that. Obviously, there are lots of other non-cancer illness that we could potentially cover. But in 45 minutes, I think you'll find that it is quite a bit that we go through. I'm hoping this session would be an interactive session. So I'm sure you're all familiar with the Zoom function and the chat button. There'll be a couple of questions. I think there are about 6 questions in between the presentation, which is called multiple choice answers. So it is just to make sure you're alert and listening. So just answer whatever you feel in your mind, and please put the answers in chat box. And I'd request Dr. Sunil to keep an eye on the chat box, see whether responses are coming. I wouldn't spend too much time on that because we need to cover a lot here. So before we start, can we just think of a patient, an imaginary patient, say George, who's about 81-year-old. He's a retired teacher, and he lives with his wife, Susan. He had dementia, which was diagnosed about 5 years ago, and his condition is deteriorating now. So keep in your mind George and this, what his problems can be. He's now dependent on all aspects of his care. He's doubly incontinent, and he's difficult in communicating. He's only able to walk 2 to 3 steps. Now, in the last 1 year, George has been seen by a general physician, neurologist and cardiologist. And he also had about 3 admissions to hospital in the last 12 months. The last admission, in that period, he was in hospital for about 4 weeks. And after each episode, he did not recover back to the point where he was before. So he came to the hospital, and then, but he didn't go back to his baseline functions. And unfortunately, in the last admission, he died on a ventilator. So thinking about George, if I just pause for maybe 1 minute, and what are your thoughts about George? If you can use a chat button, a chat function, and maybe to put a few words, what is the things that you worry about George? What do you think that George needs most in the last year of life? If you can't use the chat function, you can unmute yourself and maybe tell the answer, have a discussion. Anything about George? Anything coming in the chat, Rajalakshmi?
Yeah.
Okay.
He needs life with dignity.
Good. Yeah.
That was one response. Then rehabilitation for better functioning.
Yeah.
Measures to make his quality of life and comfortable.
Yeah.
And he need more compassion, not
Okay.
only resolving of his symptoms. Yeah, there are three people talking about quality of life.
Yeah. Okay. Very good. That's really good. I think you've covered most of the points that I was also thinking about. So the most important thing is obviously we need to think about his symptoms, and by improving his symptoms, how do we improve his quality of life? So that should be the most important thing in this stage of his illness. And obviously, when he reaches the last stage, how do we identify that he's at end of life care at the end of life point, and how do we make that better? How does that experience of end of life is better for George as well as for Susan? And obviously the bereavement care is also important because Susan has been looking after George for a long time, and now she has to live without him. So how is she going to adjust? So all these things should come to a typical palliative care physicians or any physician's mind when we think about George. So Sunil mentioned this. This is the previous definition of WHO, if you WHO definition of palliative care, which was what we had followed from 2002 onwards, which I think most of you would be familiar with. So the keywords are quality of life, life-threatening illness, and the management of the impeccable assessment of management of the symptoms. So there the concentration was on was on life-threatening illness or life-limiting illness, but we've moved on from there. So now the International Association of Hospice and Palliative Care have redefined the definition of palliative care in 2018, and this has been accepted by a consensus. So now we look for serious health-related suffering. So it can be any disease and that can cause suffering to a patient that is quite serious. That is what palliative care aims to manage now. And there are a number of diseases that has been mentioned in the Lancet report, which can come under a disease that can cause a serious health-related suffering, in which cancer is just one of them. All the other non-cancer conditions, as well as infections, hemorrhagic fevers, lung diseases, musculoskeletal disease, anything, even trauma, RT, or injury, if that is causing a suffering for the patient, then that needs our help, and that needs probably a holistic approach, which is provided by palliative care. So this is a map which predicts how the serious health-related suffering is going to change from 2016 to up to 2020, and they have divided it based on the World Bank income region. So the dark green shows is a low income and the middle income country, and we can see that we are predicting about 155% increase in the suffering for the low income countries, and low middle income countries. What they're expecting is there'll be about 87% increase in the suffering. The cases. So basically what they're saying is that the countries in the low income and low middle income countries are the ones that is going to have a bulk of the patients who is going to have a serious health-related suffering when we reach 2060. And again, how the cause of death is going to change as we move from 2016 to 60, how the global burden is changing. You can see that the malignant conditions are topping the list, so that non-communicable disease or non-infectious disease are topping the list now. That is including malignant conditions, but the conditions like CVA, lung disease, and dementia is also going to increase, and by 2060. So the pattern of illness are changing, and this actually shows the distribution of the major cause of death worldwide in the 20 years. So the death due to communicable diseases, which is shown in red color, was initially high, as is now actually coming down, and the blue one is the larger bulk of non-communicable diseases, and that is increasing. So people are tending to die more with the non-communicable diseases than communicable diseases now, and that is going to increase in the future. And the similar trend is being followed in India also. India also, being a low middle income country, we do have a higher share of communicable diseases, as you can see difference in the graph in the red portion, but that is also coming down, and our share of NCDs is also increasing. So we need to concentrate on this burden, the disease burden in the country. What we can see that about 32% of all the deaths can be because of NCDs. So which are the major ones? We've got cancer, we've got cardiovascular diseases, chronic respiratory diseases, and diabetes. And the important thing to understand is that the peak prevalence of these illnesses happens at the younger age group. So what happens is that younger age group get affected more. They tend to live more, so the burden is also high, and they need more long-term care. But on top of that, we still have got our burden of communicable diseases. So how are we going to fight both these burden together? So about 48 to 75% of burden in India in 2017 was thought to be because of NCDs. Now, this is a retrospective study that was done in UK. So it was done on a community and hospital care palliative care provision in a large UK city. It was published in 2016 in BMJ. So what they found in that study was that out of the 4,000 patients, which they included in the analysis, only 400 about 700 had a non-cancer diagnosis. And so what they tried to find out were the patients were referred to palliative care, which is whether it's cancer or non-cancer. And they found that after 4,000, about only 700 was a non-cancer diagnosis. All the other was cancer diagnosis. And the median duration of palliative care for the whole study population was only 34 days. That means before their death, when were they referred to palliative care? That was a question they asked. And the median duration was only 34 days. And for non-cancer, it was only 16 days. So UK, being the country where the palliative care is supposed to be most developed, is still doing very poorly as far as non-cancer is concerned. The patients are getting very late, about a median time of 16 days before the death. Only they are getting referred to palliative care, which is not enough, because what the research suggests is that for good quality palliative care delivery, at least 6 months before their death, the patient should be referred to a palliative care team. So first question, so in all the non-cancer conditions, so there are different symptom clusters, right? So what do you think is the most common symptom cluster which is seen in advanced cancer, as well as AIDS, heart disease, COPD, and renal disease? Is it a cluster of pain, breathlessness, or fatigue, or pain, vomiting, and constipation, breathlessness, delirium, and constipation, or option D, depression, anxiety, and anorexia? I'll give you one minute to answer in chat. You can just put A, B, C, or D. Any answers coming?
3 A's and 1 D.
So 3 A's and 1 D. Okay, yeah. Very good. So it is A. So pain, breathlessness, and fatigue are the most common symptom clusters. Now, this was published in JPSM in 2006, where they did a comparison of the symptom prevalence in advanced cancer, AIDS, heart disease, and the symptoms of pain, breathlessness, and fatigue is found in more than 50% of patients. But all the 5 diseases, it is common, so including cancer. And this is a table which tells you how common these symptoms are. So you can see, as expected, even though a lung cancer patient has dyspnea, 10 to 70%, what you can see is COPD has got more dyspnea. 90 to 95% of COPD patients, as expected, has got dyspnea. But do they get referred to palliative care input? Because do the clinicians know that COPD patients can benefit from palliative care because they're not a cancer condition? Similarly, you can see pain. HIV patients have got 60 to 80% of patients. Pain is an HIV patient. Fatigue is very common in heart failure. Depression is common in HIV, like cancer. So this is comparing with the cancer and other non-cancer conditions. You can see all the symptoms are there, but do they get enough referral to get the benefit from palliative care? So going to the individual conditions, first we look at COPD. So what they found, there's another study published as early in 2000 in Thorax, which compared the quality of life in end-stage COPD patients and lung cancer patients, and showed that the patients with COPD had poor quality of life, as well as more breathlessness as expected compared to those with lung cancer patient, but none of the COPD patients actually referred any specialized palliative care service. Now, this was quite early, it was in 2000, when obviously it was about 20 years back, but I'm not sure whether things have changed much now. So as you can see, they've got lots of symptoms, but they don't get enough referral to the palliative care services. And the another study which found was, it was a prospective cohort study of seriously ill patients and hospitalized patients with COPD and lung cancer. And they were asked whether they would want supportive care as opposed to ventilation. And equal number of patients from both the group said that they would prefer, at end of life, they would prefer supportive care. But what happened was that ultimately, when they followed up patients, they found that most COPD patients actually reserved ventilation as compared to cancer patients, 70% versus 20%. So even though the patients, end-stage COPD patients wanted to have advanced care planning and wanted to have supportive care and not go for invasive ventilation, unfortunately, the wishes didn't happen because the advanced care planning was not adequately done for COPD patients. And about, most COPD patients ended up receiving ventilation as compared to cancer patients. So what can we do if you get a, so what are the medical management, what can be done for breathlessness management in advanced COPD? Now, this table shows the different modalities of treatment which can be given at different stages in the diagnosis of COPD. So initially when they are started, they'll be put on inhaled corticosteroids and long-acting anticholinergics, long-acting beta agonist, and they start with that. And as they become worse, and we also exclude the contributing causes, they need to have a regular follow-up and assessment. And as the condition worsens, we put them on the non-pharmacological therapies. And so that means they need referral to the physiotherapist, just respiratory physiotherapists, and decent exercises, pursed lip breathing, walking aids, chest wall vibration, neuromuscular electrical stimulation. All these are the non-pharmacological therapies which can be given for breathlessness management. And once they're still breathless in spite of the non-pharmacological management, we put them on low-dose morphine. Now, breathlessness will be covered to in a different topic, so I'm not going into details about the non-pharmacological management here. But this is where, even for cancer patients as well as COPD patients, this is a point where when they reach end-stage breathlessness, they can be put on short and long-acting opioids for their symptom management. This will be dealt in detail in the breathlessness topic. Coming to the next NCD, which is heart failure. And the next question, so 1 minute to answer this question. What percentage of patients diagnosed with heart failure die within 5 years of their first hospital admission? So they get a diagnosis of heart failure, they end up being in hospital, and then how many die within 5 years? So is it 30%? Is it 40%? Is it 50% or 60%?
Majority says B option. We have 5 option for A and couple of D and C too.
Okay. So the answer is actually C, or 50%. So about half the number of patients. This is actually data from UK. In incidence of heart failure in UK is 1 per 1,000 population per year. And what we actually see is that the survival rate is worse than for breast or prostate cancer. So people with a diagnosis of breast and prostate cancer in UK survive more than those with heart failure. So, we all know that when our patient get a cancer diagnosis, we feel that's end, isn't it? But you can see that the heart failure patient probably can die quicker than a breast or prostate cancer patient. And what they have found is that half the patients, about 50% of patients, were diagnosed with heart failure. And if they have a hospital admission, within 5 years, actually they die. And the other important thing to remember is the patients with heart failure tend to have episodes of sudden death. Now, it could be because of apnea. So, so they need time to prepare for their things. They should be aware of that, and they can have a sudden cardiac arrest when they're quite well, which can take the patient as well as physicians and the carers by surprise. So that's the reason why we have to discuss this potential of sudden death, even at the diagnosis, and then the patients will need time to think about their future or plan their future if needed. Just quickly to go through the definition of, new NYHA definition of heart failure and classification, where you can see that according to AHA stage A classification, its definition is presence of heart failure risk factors, but no heart disease and no symptoms. That doesn't come in the NYHA class. And NYHA class is divided into 1 to 4, and which is equivalent to stage B, C, and D of the AHA classification. NYHA class 4 is equivalent to stage D of AHA, which is where the patient is unable to carry out any physical activity without any discomfort, and which means that there's a presence of advanced heart disease with continued heart failure symptoms requiring aggressive medical therapy. Now, the reason I mentioned this table is that the medical treatments is also based on the, the classification of the heart failure. So the important thing to remember is that, when patients get referred to palliative care, we tend to rationalize the medications because they'll be taking too much of medications, and we tend to cut them down. But the problem with heart failure medications is it is important even till end of life. So for symptom control at least. So you can see that at each stage, NYHA 1, 2, 3, and 4, the indication for different drugs are given, and diuretics probably should be started earlier on from class 2 onwards. You put them on diuretics. ACE inhibitors starts from class 1, and actually you have to continue till class 4. All these medications should be continued, and it's important because it will improve their functional status. So when you think of quality of life, to improve that, all these cardiac medications are important, and obviously they also help in survival and decrease in the hospital admissions. So these are the cardinal drugs that is important, and which we should be very, very cautious before we stop the medications. But obviously, if the risk factors are high, your patients having falls and low BP, then obviously we weigh the risk and benefit and discontinue if needed. But that will be individual choice depending on the patients. Okay, moving to end-stage kidney disease, and the next question. Now, the patients who benefit from palliative care in end-stage kidney disease are those who cannot are not advised to embark on dialysis, or those who are failing to thrive on dialysis or experience worsening quality of life, or those who discontinue dialysis, or all of the above. 1 minute for answers.
Majority says
All
D.
are Ds.
Yes, okay, well done. So it is all of the above. Those are the main things when we think about end-stage kidney disease. So there are few. There will be a cohort of patients who will reach the point when they are going to start the dialysis, but they decide due to any reason. It can be financial reason, it can be just personal wish not to be tied to a dialysis machine 3 times a week, or any reason they decide not to go for dialysis. Or that's one group of patients who can have a conservative or a palliative care approach. The other group is they're on dialysis, but they're failing to thrive, and there's worsening in the quality of life, there's increased symptom burden. Then you have to stop it, or you can add palliative care to that, and the patients will discontinue dialysis. So these 3 groups are the normal ones, are the normal group that we refer to palliative care. Now, what you can see that and other thing is, some areas like obviously palliative care provides a lot of psychosocial support and financial support, and there are patients who are on dialysis, at least in our unit, which gets free medications. All the renal medications are given free of cost by the palliative care unit. So in those patients, we get the referral quite earlier on, but that's usually for the provision of providing the free medications to the patient. Now, the important thing to remember about end-stage kidney disease is that all these patients have extremely poor quality of life. They need frequent hospital admissions, and the prognosis is comparable to the common malignancies. And again, the symptom burden is also same. There'll be dyspnea, confusion, pain, anxiety, and depression. It's very common during the last few days of life. This another retrospective study, again, this was published in the UK, where they compared the survival and the palliative care involvement of 2 groups of patients over 70 years. As I mentioned, one chose as conservative management, and the other group chose a dialysis in advanced CKD. So all these patients would reach a point in which they have to start the dialysis, and one group just chose conservative management. So what the study did was it tried to analyze the data, basically comparing the survival, the hospital admissions, and the palliative care access of patients over 70 years of age with CKD stage 5, and divide that into 2 groups. And what it found was that for patients who are more than 80 years of age, so they've got poor performance status and they have high comorbidity scores. So what happened is that those who went for a conservative management actually did better and lived longer. They had a survival advantage than the patients who went for a dialysis. So and obviously conservative management means they go straight to a palliative care approach, where they'll be seen by palliative care doctor, dietitian, all the other supportive service will be there, except the fact that they won't have they won't be connected to a dialysis machine. And what they found was that but age was a criteria, or those patients who were more than 80 years of age actually did better if they didn't go for dialysis. They did better and longer with better quality of life, and had a survival advantage also if they went in the conservative route. So this was a landmark study in UK, and then followed by they started lots of like joint clinics with palliative care physicians and renal physicians, because this was an important, and obviously it's an aged population countries, and there's lots of people with more than 80 years there who would actually benefit just by not going into the dialysis route. Okay, moving on to the next one, that's dementia and other neurological condition. And the next question. Now, which among the following is the most common symptom in advanced dementia? Is it confusion, urinary incontinence, pain, or low mood?
More A's and some D's.
Okay, so it's confusion is the answer. So this is the percentages. So 83% of patient can have confusion. Next is urinary incontinence. Pain is also quite common, 64%. Then comes low mood, constipation, and loss of appetite. Again, if you look at the symptoms, they are symptoms similar to what end-stage cancer patients probably can have. Now, how do you assess a patient with dementia? Now, especially the functional assessment, you diagnose dementia with the memory scale and mini mental state examination, you can divide, but then how do you functionally assess them? There are lots of scales that has been proposed, like clinical dementia rating scale, the functional assessment or stage of FAST scale, and global deterioration scale or GDS scale. Now, I've just briefly mentioned the FAST scale, which actually describes the stages of dementia. It's a 7-stage system based on the one's level of functioning and ability to perform certain activities of daily living, than on the cognitive decline. So basically, it is a patient has got cognitive decline, it's got dementia, but sometimes dementia patients even drive, isn't it? Driving is like an automated thing or automatic thing. So probably they're able to do that. Some people are able to do that. So, but this scale actually tells you what all can they do functionally. So you can see that there are 7 steps there. And one, there is no subjective or objective difficulties. They can do all their work normally, the early stage of dementia. Then gradually it moves on to complaints of misplacing the objects, some word finding difficulties, then organization. Then it moves on to the activities of daily living. Then at stage 5, they'll reach an assistance with dressing, to match the weather or occasion. Obviously, that is a UK tool, because they have to dress according to the weather. Then from 6A to E and 7A to F, what we see is that there'll be difficulty in dressing, so bathing, toileting without assistance. Then goes to urinary incontinence and fecal incontinence. And 7, finally, the speech is affected. The speech is limited to less than 6 words per day, then becomes 1 or less. Then they can't move completely. So inability to ambulate independently, sit up without assistance, smile, and then hold the head up. Finally, they're not able to hold the head up. That is a 7F stage. So why is it important? It's important because it tells us how the dementia is progressing. It tells us when to start the advanced care planning. So this again, I need your response in chat box. What do you think are the interventions we can do for patient with dementia? So think about George, and what do you think if you as a palliative care physician was referred George earlier on, what all could you have made a difference in his life, in end of life? So what all things are coming to your mind? I'll give you 1 minute for that. I think one I already mentioned in the last slide, so that can come. Anything, Sunil?
Yeah, prepare him and his wife for death. Advanced care planning.
Yeah.
Then memory aids, doing daily jobs.
Yeah.
Puzzle symbol. Prevent and counsel further complication, pressure source, UTI, delirium, etc.
Okay.
Supportive structure for ADLs.
Okay.
Training and educating the care provider.
Okay.
Power of attorney.
Okay. Okay, brilliant. Yeah. So yeah, advanced care plan is very important. Then, caregiver support, you mentioned all those training for the caregivers, and also the hospice referral. So basically what hospice means is that you don't have to have a hospice facility as such. It just means admission under palliative care. So if suppose a patient needs to be admitted, then rather than admitting into an acute unit or acute care unit where, they tend up going into he might end up ending into ICU and ventilator. If he's admitted under palliative care physician, they would probably give him all the treatment, including IV antibiotics, but probably wouldn't escalate his treatment to ICU. So that is similar to hospice. Hospice is actually our palliative care centers, which can provide. Some hospitals even provide IV antibiotics, some provide blood, IV fluids, and all, depending on how they manage it. But it's entirely different situation. It's not like an acute hospital busy ward where the patient is always things are running around and they don't even have the the comfort of being looked after. So more of nursing care. So you could have actually if you got involved earlier on, you could have thought of that. You could have given some advanced care planning for him, and also to avoid the conversations, to avoid a potentially burdensome treatment. So if we had an adequate palliative care, George wouldn't have died on a ventilator in an ICU, which is what Susan is going to think for days and months on. She's probably going to think about that. George could have died in a hospice with Susan by the side holding his hand, and probably had a much more comfortable death. So that is very, very important. What we can do if you get a referral at the correct time. Now, a few other conditions, neurological conditions, that potentially can benefit from palliative care input is motor neuron disease, that is ALS, amyotrophic lateral sclerosis, Parkinsonian syndromes, multiple sclerosis, and obviously the stroke, ischemic or hemorrhagic stroke. I'll just briefly mention a few symptom management issues and medications that you can potentially try. So all the symptoms of constipation would be just like other management. You can try osmotic laxatives and stimulant laxatives. Again, constipation will be taken to you for you later on, so that'll be covered. Dyspnea will be covered. Anxiety will probably come under psychosocial symptoms, but you can manage with medications for that. You can try some medications of fatigue. You can give psychostimulants for that. Pain, for the WHO, you've had your pain session already, but you can try, if it's muscle cramps and all, you can try these adjuvant medications. You can try even weak opioids can be tried, tramadol or tepadol can be given. If there's neuropathic pain, obviously go for and tricyclic antidepressants. If there's pseudobulbar effect, you can try some quinidine or dextromethorphan for that. And pseudobulbar effects mainly in some neurological conditions where patients can become, the nervous system is affected, but they can become, they can just make you laugh or cry, become angry without being able to control their symptoms. So it's called emotional dysregulation, and there's some medications suggested for that. Now, other symptoms like hypersalivation, you can try amitriptyline or even hyoscine patches are available. Psychosis, QTPN can be tried. Sleep disorders, respiratory failure is mainly for the motor neuron disease and or ALS, where again advanced care planning and conversations are needed to see whether they are a candidate for NIV and tracheostomy. And obviously for Parkinson's disease, you can try various medications and patches. And end stage, you can even give midazolam to help with their spasticity. If they got insomnia, you can give them amitriptyline or mirtazapine, and even short-acting zolpidem, etc. drugs. Spasticity has got specific treatments for that, baclofen, tizanidine. And secretions are another important thing that comes in the neurological patients. So you can give either, if it's thick secretions, you can give mucolytics, or you can also give, if it's thin secretions, to dry up the secretions, you can give glycopyrrolate or buscopan for that. Another important topic is frailty in old age. I think it's going to be very, very common and probably going to be a bulk of our population. Geriatric care and palliative care is obviously going to be mixed together. There's a lot of involvement, there's a lot of common things. So next question, next quiz. What percentage of world's population is projected to be over 65 by 2050? Is it 15%, 16%, 17%, or 18%? That's just a guesswork. You can pick your favorite number. Okay.
More D's than C and A.
Okay. 16% is the answer. Sorry. So by 2050, it's projected that 16% of the world's population will be over 65. And so that's very, very important. So if you've got elderly population, then they become more frail, isn't it? So what is frailty? Frailty is a diminishing capacity to withstand the stress. And and that's the reason why they are more vulnerable to have adverse outcomes, and that make them more physically disabled. That makes them have difficulties in doing the daily activities. They become socially withdrawn. They can have slow motor processing. They can have cognitive changes, weight loss. All these there won't be a specific diagnosis of an illness. It's all part of the package of frailty. That's why elderly people behave like that. What is the risk of that? Why do you have to worry about frailty? Because once they become more frail, there's increased risk of falling. Obviously, then they tend to be hospitalized more. Then they come back, they'll be reduced activities of daily living, and they become more disabled. Now, what they found is that people are tend to be living longer, so they're doing more research on this. And what they found is that if you can actually delay the frailty, 3 to 5% of deaths in older adults could be delayed if frailty was prevented. So people have been trying to do research on that and to see how we can actually prevent the frailty. So how can you prevent? It's going to happen, but how do you prevent it from happening quicker? So primary prevention happens everywhere for NCD. So address a comorbid illness like hypertension. Secondary prevention for chronic disease management, exercise and nutrition. And in tertiary prevention of frailty, good palliative care has a role for that, for maintaining and improving function, control of symptoms, and maintaining the psychological well-being and preventing hospital admission. So again, in my unit where I work currently, geriatric care is part of palliative care, and all the geriatric patients have to be mandated referred to palliative care of the district. And we do tend to have, nurses tend to visit them quite frequently, and the small symptoms, we tend to actually sort them and manage at home to prevent the admission to hospitals. So that's one of the important areas, and it is going to grow because obviously the world population is aging. So the role of palliative care in geriatric is also going to increase. Okay, and coming to major psychiatric illness. Next question, what's the prevalence of major depression in oncology? Is it 10%, is it 38%, 60%, or 70%? Okay.
There are all the choices.
All the choices, okay. It's 30%, 38% is the answer. So that's the prevalence of depression in oncology is 38%. So how they diagnose is that it's not just the depression alone. It's basically depression associated with other medical conditions. So it comes under DSM-5 category, where depression is because of a physiological result of conditions like hypothyroidism, chronic uremia, and presence of cancer-induced cytokines, medication effects of steroids, and chemotherapy agents. So that's why when a patient has got a diagnosis of cancer, obviously, you just say in layman terms, you just say they're depressed, they're low in mood, but they can potentially have a diagnosis of depression, having classic features of depression because of these reasons, and it comes under a DSM-5 category, and it's quite common. So why is it important? Because untreated depression can affect the treatment adherence. So, patient is having depression, they cannot reduce understanding about the diagnosis, and their treatment decisions can also be, they can be non-compliant, and they'll be pessimistic about the outcome and benefit. They can't tolerate the side effects well because already their mental health is not working properly. So they can isolate themselves, and they have poor family support and reduced use of community resources. So all these, it's important to identify. So rather than saying that, okay, he's got a cancer diagnosis, then he has a right to be sad. That is true. But we probably, it's better to assess a patient properly and screen for depression and see whether a patient has got a diagnosis of depression. And there are various screening tools available. The common one probably that we use in cancer patients is distress thermometer. You can also use the Beck depression inventory. So NCC and the National Comprehensive Cancer Care Network actually recommends having a periodic screening of all the patients undergoing chemotherapy to know whether they've got depression or not. And you can even ask a single question like, are you depressed? Are you low in mood? Do you feel low in mood? It's very, very important to know that, mainly because if it's untreated, as it is, the patient can have pain and other symptoms which can limit their functions. and the spiritual well-being can be affected. All these can work together, and they can feel their life is meaningless. Depression can happen, and that's when people tend to go for thoughts about death and suicide, and assisted suicide all happen. So it's because of untreated depression and other psychosocial reasons. So it's very, very important to know that. I'll briefly go through the antidepressants. It's not different from the classical one. So you can use amitriptyline, what we normally use. You can use citalopram, venlafaxine, citalopram can be tried. And there are different indications, so different uses in palliative for all these drugs, not just depression. We all know about amitriptyline being used in pain. If you can other medicines like selective dopamine and noradrenaline reuptake inhibitors can be tried. Mirtazapine is a newer variety of antidepressant, which actually in palliative we've got lots of uses for mirtazapine, including anxiety, depression. We can also give it for appetite and weight gain and insomnia. So it's one of the favorite medications of palliative care physicians. You can use 15 to 60 milligram dose for depression. For mirtazapine, helps with sleep, also helps in appetite. Then SSRIs, trazodone can be given. And if the other important group is psychostimulants. Now, psychostimulants are a group of drugs, including methylphenidate and modafinil, are a group of drugs which are given when the prognosis of the patient is quite short. So you know that conventional antidepressants will take some time to start working. So at least 4 to 6 weeks is needed for the antidepressants to start working. But if the patient's prognosis is quite short and you don't have much time with them, but you need to make sure but you know that they're clinically very, very depressed, you can give a trial of psychostimulant, including methylphenidate can be given for depression. Okay. So I'll come to the last portion again, I would like your opinion on the comment box. So what do you think is a barrier? So you as a non-palliative care doctor, or you as a physician, or you as a respiratory physician, or a non-cancer doctor, non-oncologist, what do you think is a barrier for such doctors to refer the patient to palliative care? Just put a few thoughts in the chat box. Why do you think the non-cancer patients don't get referred to palliative care? Anything coming in?
Yeah, less knowledge, lack of awareness among doctors. It's mainly about knowledge when to refer.
Yeah. So I would say that's the most important thing, isn't it? We don't know whether we can refer such patients for palliative care. The other thing is non-cancer patients, we can't definitely say how long they have got, because people tend to get admitted with a very bad illness. You have discussion with the family about they're going to die, and the patient get better and go back home. This keep on happening. So you'll be thinking, oh, am I going to be right this time? So we don't know how long the patient has got. The prognosis is not there, and also the doctors haven't decided to be optimistic, and we don't want to alarm the patients or the family about impending thoughts of impending death. Sometimes we do if you accept palliative care, we just feel that it's a failure on the part of the doctors, because palliative care equals death. So you don't want to think that we have failed as a doctor. Lack of specialist case resource, palliative care service available, hospital policy, lack of skills in symptom control. And even the patient and families also has the same problem. They would think, okay, why should I go for a palliative care doctor because I don't have cancer? Caregivers, even though you have a conversation with the family, sometimes the caregivers are unprepared. They don't want to accept the fact that patient probably only needs comfort care and they don't want any aggressive treatment. Sometimes the caregivers find it difficult to accept that, so they don't recognize as a terminal illness. So how do we help these doctors to recognize when to refer to palliative care? So we've got an important tool. We can refer this later. It's called the Supportive and Palliative Care Indicator tool, called SPIC tool, which it gives us different trigger points of different illnesses where you can actually refer. We can think about starting referring to palliative care. So as I mentioned, in heart failure, if it's an NYHA class 3 or 4 heart failure, or extensive coronary artery disease, or breathlessness, peripheral vascular disease, gangrene. If it's liver disease, we didn't cover liver disease today, but if you think of end-stage liver disease, advanced cirrhosis, if it's diuretic resistant ascites, needing recurrent drainage, hepatic encephalopathy, hepatorenal syndrome, bacterial peritonitis, or varicose vein. So just to mention about liver disease, again, our unit, our palliative care nurses are trained to provide ascitic fluid tapping at home. So that is an important referral that we get for patients. So we especially in the COVID period, when we want to avoid the hospital admissions, we're encouraging our nurses, we're training our nurses to do that at home. And lots of patients are getting ascitic fluid tapping at home. We take up to 5 liters of fluid. We take up to 5 liters of fluid in one sitting at home. So that is again another role that we can play. Kidney disease, as I mentioned, stage 4 or 5 kidney disease, kidney failure, when you stop the dialysis, or advanced diabetes unresponsive to treatment with the deteriorating health and kidney failure. So what do you tell? So what do you actually tell them? So any patient, the access to palliative care should not be just be based on a diagnosis. It actually should be based on the need of the patient. So as we mentioned when I first started, any patient having a serious health-related suffering, SHS, actually needs palliative care. But the one strong recommendation that we tell is that anyone, so it's a surprise question, would I be surprised to see this patient? So if you're seeing a patient OPD and looking at the patient, you ask this question to yourself, would I be surprised if this patient is died in the next 12 months? So basically, you're not surprised if the patient dies in a year. That means you think that his prognosis is less than 1 year. Then maybe you should think about referring that patient to palliative care. That's a surprise question. So to conclude my busy session, so palliative care is needed for all the patients with serious health-related suffering, which can include both cancer and non-cancer. And obviously, there's a need for further research into the needs assessment tool for specific conditions, as well as evidence of benefit of the palliative care environment. Thank you very much for listening, and please ask any questions or any comments.
Thank you, Sunitha. The session is open for discussion.
I also put a link in the chat box. It's a feedback form just for my personal. You'll be probably getting another feedback from Palliative India, but just for my session, if you can fill that in, it's just for my feedback for my presentation. I'm really grateful, and I hope Rajlakshmi can share that link with them afterwards also in email or WhatsApp. Thank you. So there's a comment in chat that elder patient can be given palliative care. So is that a question? Are you asking whether, so that's what we said, geriatric patients should probably be referred to palliative care just as a baseline to see whether they can be given any, any help or any support can be given.
Okay, so what kind of need assessment for palliative care are you planning?
So, I think, so in India, we are actually developing a tool. So after this SHS article was published in Lancet, we have done a Delphi process. We are actually in the process of developing a tool to assess a serious health-related suffering. So SHS tool we are developing in India. So all the domains that is mentioned in that, this is in the developing process. So we have the tool has been formed. Now actually we're going to pilot it in different hospitals in the country. So once that is ready, probably it can be adapted to other LMIC settings also. But there are lots of needs assessment tool developed in the Western population. There's something called NATC that UK uses. And I think there's palliative care needs, there's lots available in the Western population. But just for India, I think we are developing one right now.
Which is the best antidepressant for someone with a chronic kidney disease?
Chronic kidney disease, I will have to check that. I'm sure mirtazapine is safe in renal failure. But what I normally do is, if it's chronic liver or chronic kidney disease, specifically what I use is, if I think of an antidepressant, I check the SPC, that means product characteristics, and see whether there's any contraindication or dose reduction needed for renal failure, and adjust accordingly. That's what I normally do. If it's liver or kidney, we adjust accordingly. Anything else for Sunil? That
any specific? No, I think the only thing which is contraindicated in renal failure is duloxetine.
Duloxetine, okay.
Yeah.
But duloxetine normally we don't use as a first-line antidepressant,
Yeah.
right? We give for pain only. So,
Yeah.
yeah, I think escitalopram are the ones that we use. And but my favorite is mirtazapine for depression. So what I would do is I'll check the renal dose and start that. Somebody has asked dementia treatment. I don't know.
Yeah.
You don't have a session on dementia by Dr. Chitra, right? You don't have that, right?
No, Sunitha, we don't have.
So I think the drug for dementia that is it's available in India, isn't it? The Alzheimer's one. What was it called?
Memantine.
Yeah, memantine. So that is the only one for Alzheimer's. So that is what we give here. And for vascular dementia, actually, it doesn't work. So you have to have blood pressure control, etc. Even that drug, it only shortens the progression by like few months.
Yeah.
That's it. It's still going to progress, and it still will need palliative exit. It's not a curative drug, but we start that here, isn't it? No, donepezil is the other one. Memantine and donepezil, advanced dementia. I think if the patient is tolerating the medication, you can continue. But suppose Solo's issues come, then obviously you'll have to stop that. Because after one point, it stops working. It should be given, there's a time when you have to start this medication, and then it is slows the progression initially on. Once it's advanced stage, I don't think they've got much role. But if the patients can afford and they can continue, then we just say, and then they tolerate, then we just say continue. That's what I normally do. Okay, more comments coming. Okay, how can dementia patients communicate pain? Again, that is a important question, and there's a separate tool for that. I probably should have mentioned that. It's one of those tools where one is how patients communicate using grimace and all. So it's a tool that's available for like a pain score, where you can there's a non-verbal communication, and you can based on that you can know whether they've got pain or not. Do you know the name of the tool, Sunil?
Which one, Sunitha?
The non-verbal communication in a dementia and cognitive impaired patients pain scoring.
Pain scoring, yeah. In dementia, there is pain assessment in advanced dementia. That is PAINARD scale, and then geriatric. Something I don't remember.
PAINARD tool. It's called PAINARD tool. Yeah,
that's PAINARD. But for other non-verbal patients, there is some gerontology or geriatric something. I don't remember it correctly.
Okay, I've given you the link for the PAINARD one. You can click on that and read that. Okay.
They're asking for more case discussions regarding non-cancer palliative care. But I think we have a very good patient story for this session.
Okay, we'll go on to that.
The aim of this session is to enlighten you regarding the importance of palliative care in non-cancer illness, because many of the centers are doing only palliative care for cancer patients. So it is for you to understand that the other patients also suffer due to many things like the cancer patients' symptom burden. So that's what the aim of the session is. But we will try to incorporate more sessions in the coming foundation course. And let us see whether we can present more patient stories. Anything else? Sunitha, I think another drug which is available is rivastigmine.
Yeah. It wasn't that specifically for a type of dementia?
I'm not sure. but I have seen that's a cholinesterase inhibitor.
Yeah, inhibitor. Yeah, that's true. Yeah. Okay.
We will try to send some articles.
You can actually share this presentation, right? And
Yeah,
that has got
yeah,
lots of link,
yeah,
references
yeah.
probably it's in there.
Mm.
So, they will share the presentation with you. But all my reference are quite outdated probably. So, you could have newer ones also.
So I think we can move on to patient story. So today's patient story will be presented by Dr. Abir. So Dr. Abir, it's over to you.
So, good afternoon, everyone. I'm Dr. Abir. My primary specialty is actually emergency medicine, but currently I'm working in one of the cruise ships, actually Royal Caribbean cruise ships, which is based in Florida. Even though it is based in Florida, as you know, when I work on ships, I'll be traveling most of the time. And currently, I'm on board a ship in Singapore, and I'm in the seas, and I'm talking to you from Singapore in the ship. So in between, my connection can go. In that case, I'll just wait for a few seconds. It will reconnect again. Okay. Having said that, this story of this patient actually is not from the ships. Even though we do get, I've been working in the ship last 2 years, and we do get palliative care patients in the ships. In my last contract, I think it was from Texas. We had around a group of 100 people coming with small kids who are terminally ill, like non-operatable brain tumors. So it was a group of 100 people brought by one of the organization. I think the name of that organization was Make a Wish. So they brought these people as a part of their last wish to be travel on a cruise ships, and that was nice to see them on board. And I have to deal with one of the kid who had a seizure. But this patient, actually, this is my own uncle. I'm going to talk about him. He's around 65 of age, male patient. The diagnosis was advanced cortical dementia, and later on he developed an acute subdural hematoma, then underwent a decompression craniotomy, later on urosepsis, and he was known with diabetes, hypertension, and CAD. So the presenting complaint, actually, why we took him to the hospital for this particular reason was like he had a history of recurrent falls followed by vomiting. So coming to the history of presenting illness, so if you go to history of presenting illness, his dementia actually started more than 10 years. So in the initial stages, he used to complain like, I forgot the names of people. So if you meet somebody on the way and he's, not very close to him, he will forget their names. And then after some time, he will ask them, if you meet him today and next day again, he will ask, oh, what was his name? I forgot his name. But then the family or any of one of us didn't take it that seriously because, maybe a part of stress and it was what we were thinking. But then it gradually progressed, and gradually he used to forget to pay money when he buys something from a shop. He used to come without paying the money, and sometimes the shopkeeper will call us and tell no, he forgot to give the money. And sometimes he even argue with the shop, no, I paid you. And it was when this financial transactions got a problem, it's what we started noticing it. And what happened was and it was like gradually progressing, and in until this last stage, actually in the last 6 months, if we could see, he was not even recognizing his spouse. It is not spouses, it is spouse. It was a mistake. There was only one wife and children. He was not even recognizing them at this stage from the last 6 months. So maybe, and when we could in the presentation, actually Dr. Sunitha was talking about the six stage, maybe probably it was in the stage 6, and he had a recurrent urinary incontinence also. He used to complain of recurrent urinary incontinence. And in the last 3 months, actually, what they used to see was like he used to lie down on the floor, and sometimes when they won't see him, and he will be on the floor and he'll be sweating a lot, and after that he will have vomiting for maybe few hours, and then he becomes okay. And this process continued in last 3 months, like once in a month or then. And in the last 1 month, it was like almost every week he used to have this thing. Okay, and he was a particular person. Actually, he never used to take this allopathic medications. Even he will ask me about so many doubts, but he never takes medication. Not only he, most of his wife and his kids, everyone. So for this dementia thing, also he was consulting an Ayurvedic treatment center, and they were doing some treatments, and they were on some this Ulchil therapy and all those things. Except the only thing allopathic medication he was taking was, he was once had a chest pain, and he had a MI and had an angioplasty done for, so he was taking dual antiplatelets, aspirin and clopidogrel, and then and telmisartan for hypertension. Even for diabetes, he was on some Ayurvedic medications. Okay, so next slide. So on this particular day, why he went hospital was because of his recurrent falls in the last weeks, and he had actually in one of the falls he had hit his head and he had a laceration and it was switched, and in that time actually we took a CT which was normal. So and on this few last fall episodes, once they witnessed, actually he was sitting in a chair, and then he had a peculiar movement of his neck and a rolling of eyeball, and then he almost fell down. So the previous episodes was unwitnessed, but this was most like a seizure, and so that's the reason by which they took him to the hospital to see whether anything can be done. So on examination at the hospital, he had difficulty in walking. He was able to stand, but to walk, he needed few support. But he was walking until the last fall was maybe yesterday. So until then, he was walking properly. So after this fall, he had this trouble in walking, even though he was not very strong in walking, but he was able to walk. And on exam, he was swaying to one side when he was walking. He had a sutured laceration on the scalp, and he was unable to speak. And initially, actually, he was speaking few words, maybe a little bit, maybe 3-4 words. That's it. But now he's almost aphasic. His Glasgow Coma Scale score was for 13. Eye opening was full. He was following commands, and the only thing's verbal response was only 3. Pupil was equal and reacting to light. Blood pressure of 200/100 and a heart rate of 72. Next slide. Okay, so the treatment plan actually discussed with the neurologist. What he told was, we'll do an EEG and an MRI to see whether anything which is possible, because in the initial CTs was showing a little bit of hydrocephalus, or whether we could put a drain and do that fluid, and whether that was the plan. But when we did the MRI, it was showing an acute subdural hematoma with midline shift. So the discussed with the neurosurgeon, actually the plan was whether we'll wait for, if it's remaining in the same GCS, we'll wait for one week or something, so that if it gets organized, and then we can do a butthole craniotomy. But he was admitted, and then the next day morning the things got worse. His GCS dropped to almost E2, M4 and V1, so almost 6. GCS was less than 6. And so when the repeat CT showed and continued the bleed, which was increased in size with midline shift increasing. So then the discussion was to continue with the decompression craniectomy, and the craniectomy was done, and then he had a very stormy post-operative course. And after the craniectomy, he was in the ICU for almost 2 to 3 weeks. After craniectomy, 48 hours later, his GCS was the same. So then they told, anyway, we cannot keep him on ventilator for a long, we'll have to go for a tracheostomy so that we can slowly wean him. So tracheostomy was done, and then he had multiple episodes of hyponatremia, hypokalemia, all those things. And as usual, any patient on a tracheostomy, he developed a multi-organ infection, hospital-acquired infection. And so he was on multiple antibiotics, like meropenem and these things. And he had a continuous diarrhea following that. And this in the ICU, he had several times diarrhea, so wetting, soiling his clothes. So basically, after almost 3 weeks of in the ICU, he was out of the ICU with the same GCS when he was in, with an additional Ryle's tube and a Foley's catheter and a tracheostomy tube, and in addition to that, bed sauce. So that was how he came out. And next. Okay, before the psychosocial aspect. And then after that, he had to stay in the hospital for another 2 weeks in the room, in the ward, looking after this tracheostomy care. Oh, just a minute. Can you hear me?
Yes, we can hear you.
Okay, so and after that it was like the tracheostomy care, feeding tube, and all this and this multiple infection. So he has to be for another 2 weeks, and then later on from there, they told we will refer him to another hospital which is nearby, so that it will be better for you to look after him, something like a palliative thing. But then he was brought into that hospital and it was the same thing. But then finally I decided to bring him home with a tracheostomy tube, and with the help of the palliative care people. I've been working in the palliative care there before I came here, so I've been having good contact with them. So then we plan to treat him home. Every 1 week or something, he used to get this recurrent episodes of sweating and fever, and so in between we had to take him to hospital back again for multiple antibiotics. And finally then what we did was, with help of the palliative care team, we used to treat him at home. And for this, whenever he had these infection features, we start him on antibiotics. And sometimes he had this hyponatremia. I used to give him 3% saline from that, and sometimes hypokalemia and potassium correction. Even I had to give a blood transfusion at home with the help of the palliative care doctor and nurses over there. Coming to the psychosocial aspects, so he had 3 children. He is actually a retired NRI, so he just now looking after his rubber plantation. On the last 1 year, maybe he is not working. Okay, so then, and his 3 children, two of daughters are married and they are with their husband. And the son now wake up because of all this, like in the last 6 months, because we were not able to manage him at home. It was like kids. He lock the room, he may just walk out of the home and we don't know where he went. So his son have to come back because his wife was not able to manage him alone. Was one of the issues. He left his job and he came back here. And the daughters, one of them who was also abroad, she came back with his kids to stay with him to look after the father. And the family is actually well to do, so that maybe the both of them can survive right at this point of time without a job. So, and he's now bedridden. He's so that is right now their situation. So there was medications on until he was brought back to home. Like he was on injection meropenem 1 gram 8 hourly, almost 3 weeks, I think. And colistin 4.5 million units 8 hourly. Fasolin 100 milligrams 8 hourly. And he had recurrent seizures post-operatively. And he was put on fasolin, levetiracetam, carbamazepine, and two or more other anti-epileptic drugs was there. And on telmisartan for blood pressure and for the diarrhea and enterogermina. Next slide. Okay, so about the concerns, one of them was prolonged hospital stay during the COVID-19 time. So even during this surgical and post-surgery in the ward, there were strict protocols of COVID. Like there was only one or two bystanders allowed. So it was very difficult to turn him and to look after him. All those things was very difficult. And it was the first time that this family have to face a situation like this. So looking after tracheostomy or RT feeding, it was actually it was very new to them and they had very trouble with that. But right now with all those trainings and they're doing it by themselves now, the tracheostomy care, RT feeding. And the recurrent diarrhea, I don't know whether it was antibiotic induced or not. That was another issue. So soiling of his clothes and the bed sore was another. And the recurrent hospitalizations, even after coming back home, like because of sepsis and electrolyte imbalances was another issue which was faced. Next slide. So to summarize, it was a 65-year-old male with advanced dementia and developed acute subdural hematoma secondary to fall. Later on underwent craniectomy, tracheostomy, has now bedridden with prolonged hospital stay, recurrent hospitalization. And I would say, I would thank my palliative care team for managing him right now. He's still at home with their care. So discussion points, one of the most important thing I feel guilty about, that I was the one person who signed his operating consent. Should we have operated on him, a patient with an advanced dementia with an STH?
Definitely, you have to decompress him. That's not.
Doctor, you can continue.
Yeah, okay. And about this recurrent hospitalization, if he's on this level of palliative care, actually whether we should take him to hospital every time, or rather than better to treat, like instead of going to a hospital for admissions, we can treat at home. and how to manage this recurrent diarrhea which is facing now. Also, when we were treating this hyponatremia and hypokalemia or all these things at home, is it advisable to do so, or do we have restrictions to do so as part of palliative care? And as a part of dementia is concerned, like any suggestions, like anything for a preventative strategy for a dementia to progressing that? Because if this dementia started right around 10 years back, so that means when he was only 55. So is there anything like other non-communicable disease, any lifestyle modifications or these things which we can suggest to improve the progression of dementia? That's all.
Thank you, Dr. Abir, for sharing a personal story. Anybody can comment on any of these points?
Thanks, Dr. Abir. I think that was a very good story. And I'll just say a few of my thoughts on this. And I think the first question is, it's a very difficult question, isn't it? It was an acute bleed. And, he was, even though he had dementia, probably that was an emergency situation where anybody would have done that. So I don't think you should be hard on yourself for, signing that consent form. It was done in his best interest. And obviously the doctors who offered to operate him would have thought that that's going to help him. So they were the one who made the decision, and you were just as innocent bystander. So I don't think should be hard on yourself on that. We all know that patients like this who has got a major surgery, the recovery period and what they go through, it's going to be prolonged. It's understood, isn't it? He has to come back to his baseline. So it is important to have a conversation earlier on. So if the doctor didn't initiate that conversation, then probably this was the route this was going to go anyway, isn't it? So I wouldn't say against that. And I think it is a difficult decision at that point. We have to stop being a doctor and start and be related to the patient, which is very, very hard. I would definitely advise against recurrent hospitalization. So that is definitely precious. So once it's done that and once it's come back to home, then probably we should have an advanced care planning and decide on what all can be done at home and what all can't be done. Now, regarding what we are doing in my state or my district right now, mainly because of the COVID-19, people are very, very afraid of going back to hospital now. So we have started telemedicine services, and what I have done is I'm sort of leading the telemedicine service in the whole district of Ernakulam, where any of the patients in the government setting, if the nurses have got any concerns, I do a video call and assess the patient at home and see what all can be done at home. So for say examples of cancer patient or non-cancer patient, if they've got delirium, so we managed to get some bloods done at home. So we organize a lab to come and take some bloods from home, and even treating. So what I've done so far is I've given IV calcium at home. I have given IV potassium we haven't done, I think, but you can still give slow IV fluids of slow potassium bag is okay, but it's definitely IV that can't be subcut. Hyponatremia, what I generally do is, it's important to know the cause of hyponatremia. So if you all know that when patients go to hospital, we tend to do a serum osmolality and urine osmolality, and then we sometimes don't interpret that. So and depending on, based on a study that I did on a few patients, I've actually developed a sort of like a protocol whereby if you assess fluid status of the patient and just get a serum osmolality value, we can actually decide whether they can have bactans or not, depending on the cause of hyponatremia. So it can be either pseudo hyponatremia or it's hyper, it can be pseudo or just proper hyponatremia. And then depending on the volume status, if they're euvolemic, if it's bactans are used only if it's SIADH, isn't it? So if you get a different diagnosis of SIADH.
Sunitha, your sound is very low.
Okay. So if there's a definite diagnosis of SIADH, probably we can consider giving them Vaptans at home. I wouldn't give hypertonic saline at home. That I've never done. So depending, sometimes the hyponatremia is because of the low sodium or because they're dehydrated. So you could potentially give them normal saline at home and consider the use of Vaptans at home. But if it's symptomatic hyponatremia with seizures and all, and you definitely think that the patient would benefit from going to hospital, then only consider transferring. Because sometimes the hyponatremia and hypokalemia could be because the disease is progressing. It's not reversible, it's not correctable. So at that point, maybe it's better to give some fluids and keep them at home. So those things we have done. Again, the scenario is different now because post-COVID, we are justified in doing such things at home. And definitely IV antibiotics, again, if the patient or bystanders can have nurses who can come and give, tedious dose of antibiotics, we have encouraged to do that, and bystanders are happy in doing that. Sometimes if we really have to give IV antibiotics, and we have done that at home also. So there are things that we can do, and that needs a lot of support from the family as well as like a basic nursing support. So it depends on how much the patient and the family can afford and can do that. And how to manage recurrent diarrhea. Normally what we do is, so again, check whether it's overflow diarrhea or not. So constipation, rule out constipation, it could be overflow diarrhea, so do a proper PR. And the ones that we normally give is the loperamide, or even if it's intractable diarrhea, we give opioid. And sometimes, the lactobacillus and Vislac can be given. Sometimes infected diarrhea, then you can give, especially if it's after antibiotics. I don't know, we do C. difficile test, toxin test, Clostridium difficile has been done or not, but even without that, empirically, I've given Metrogyl for some patients and the diarrhea has settled. So again, try to find the cause of diarrhea and manage accordingly. What else is there? Does palliative care have a boundary? So I didn't understand what you mean by that. Could you just elaborate a bit?
No, yeah, that's what actually treating this people with potassium, IV potassium and IV sodium 3% hypertonic saline, is that allowed in case of in view of palliative care, or should we restrict not to do that?
Yeah, so I think that all needs proper documentation with the family, proper communication with the family, and maybe documentation also. Like if you know that IV calcium gluconate is, we give for hyperkalemia, it's a bolus push. But when you have hypocalcemia also, and that sometimes we do in a monitoring setup. But as I mentioned, I have, when patient had hypocalcemia and had some symptoms like tetany, and they didn't want to take the patient to hospital, I have told them, I've asked the nurses to give calcium, but slow IV at home also. So these are things which has to be taken by case basis and have proper communication with the patient and the family to see whether they're happy to do it at home. Anything else?
Regarding this diarrhea, actually, I've done a PR and it was not a spurious diarrhea. It was actually probably maybe this C. difficile could be a cause possible, but I didn't do a test, but possible.
I don't think C. difficile. I tried to do for one patient and the lab was not doing it in Kerala, but I gave empirically Metrogyl, and you can also give oral vancomycin for C. difficile. So that's probably another thing that you could have tried, but yeah. So somebody has commented sodium, potassium, we can't test at home. It depends on the lab and where your patients are. So that sometimes lab offers to come to take the blood from, at least where we live, where we work, they do that. So you just give a form and the lab technicians come home and take the blood, and they give the results back. And if you've got nurses who can help with that, then the nurses can take the sample, and the bystanders can take it to the lab. So we have to measure sodium, potassium, then only we can correct them. Otherwise, we're not doing it.
Yeah, it was the same thing. Like the lab person comes, he comes home, he takes the blood, and then he WhatsApp the reports. That's how it was working.
So Abir, have you seen now?
Sorry?
Have you seen now?
How is it?
He is now actually he's better in the sense his GCS is the same, but now this recurrent hospitalization is not. Since last 1 month he has not gone to hospital, and in the previous month we have given antibiotics and this sodium correction from home, but this month there has been no much issues. He's just managing it like that, and the diarrhea is, they say diarrhea is better, but I am not at home right now, but they say the diarrhea is better. And the other thing, he is bedridden, and the tracheostomy care and those things are going on like that. But now at least the family knows how to take care of this now. That is one good thing.
So uh, uh, when actually many of us, including the professionals, they don't understand dementia as a terminal disease.
Yes.
They what they see dementia as it's just like another disease, and they will think, okay, cancer is a worse disease, but dementia is not. But this is what something we have to correct. And uh, I think this is the most important thing that we have to understand in case of dementia. It's a terminal disease. And when the patient is cognitively okay, we should actually discuss with the patient regarding the problems that can happen, and ask his opinion regarding what should be done if something like this occur in the future. So advanced care planning is something, even though which is not practiced very commonly in India, I think we have to ask this to the patient and family, so that many of these questions we don't have any doubts when we do something. So you are in doubt whether we have to do this, whether we have to do this. I think this actually has to be managed by advanced care planning.
Yeah, very true. Actually, as you told, majority of us don't think dementia as a palliative care patient. So that's true. Even when if you see, look at the palliative care patients of our area, most of them are majority of them are cancer patients, and very few have been bedridden with stroke. And the dementia as such is, as you told, we don't even think about an advanced care planning. So that is one of the good take-home message which I got from after listening to the lectures. Thank you for that.
And I think I read a Lancet Commission report on dementia. It says there are some modifiable risk factors which can prevent or delay up to 40% of dementias. So these are, I can actually send it to all of you, but it says encourage the use of hearing aids for hearing loss, and reduce hearing loss by protection of ears from excessive noise exposure, reduce exposure to air pollution and secondhand tobacco smoke, prevent head injury, limit alcohol use, avoid smoking uptake. So there are many which I can send you.
Okay, yeah, that's important. Yes. Oh, so what I have been read in the last few minutes, some of these nutrition journals and these things, they say that, like any other non-communicable disease, a daily exercise of at least 30 minutes for at least 3 times a week has a very good impact on even in the progress of dementia, or even it can delay dementia by a few years. That's what they say.
Yes, I read that. Yeah.
Good to know.
How is he? How are they feeding him now?
Actually, they're doing a rice tube feed.
Okay.
And I exactly doesn't know what exactly, but they have a chart written given to them by the dietitian, so they're following it like that.
Okay. I would also like to tell you that somewhere I read that patients with advanced dementia has an median life expectancy of 1.3 years. And once they have pneumonia, then the chance of survival for 6 months is less than, I think it's about 40%. So there are some, these are from some literature. Um, so I think these are something which we can consider while we plan any treatment. Sunitha, anything else to add?
No, sir, no, I've mentioned everything. Thank you.
Anybody else has any comments? Somebody has written Algo Plus is another pain scale which is easy to use. Any food that can protect from dementia? I don't think there is an evidence to say something on that.
Other NCDs, vascular dementia is obviously because of the high blood pressure.
Sunitha, low volume.
No, vascular dementia is because of the high blood pressure. So controlling tight blood pressure control is important to prevent them from getting vascular dementia. So all the NCD management is actually important here also. But again, diet also, I haven't heard about anything.
Yeah, the Lancet Commission says aim to maintain the systolic BP 130 millimeters of mercury or less.
Okay, yeah.
So I think we can wind up the session. So thank you, Dr. Sunitha, for having a very thought-provoking session and giving a very good insight into the non-cancer palliative care. And thank you, Dr. Abir. So that was, even though that was from your personal side, but it was a very good patient story to discuss. Hope and happy to note that he is very well taken care by the palliative care team. So thank you all.